Dear Chair, dear audience, my name is Kinga Kovács and currently I'm a pediatric resident at the Department of Obstetrics and Gynecology, and I'm a PhD student as well. Our vision is that the focus in neonatal care should be on eliminating as many complications of prematurity as possible. That's why our mission is to investigate perinatal risk factors. To achieve these aims, here are our scientific goals. One is related to the histopathology of the placenta and the umbilical cord, and the other one is related to the apnea of prematurity. Our first project is a systematic review and meta-analysis, investigating the prognostic role of concomitant histopathologic fetal inflammatory response with chorioamnionitis. First, I would like to give a little explanation to these terms. Chorioamnionitis means the inflammation of the chorioamnionic membranes, and since here the vast majority of neutrophils are of maternal origin, this is the part of maternal inflammatory response. And as this inflammation progresses to the fetal direction, it reaches the fetus, causing fetal inflammatory response, and its part the chorionic vasculitis and the inflammation of the umbilical cord known as phoenicitis. Intrauterine inflammation is one of the leading causes of preterm deliveries, and several studies have showed association between chorioamnionitis and different adverse outcomes of prematurity. However, the impact of fetal inflammatory response in this equation is still unclear. That's why our aim was to investigate the role of additional fetal inflammatory response with chorioamnionitis. Our population included preterm neonates or very low birth rate neonates, and in the exposure group there were neonates with chorioamnionitis and fetal inflammatory response, and in the comparison group there were neonates with chorioamnionitis alone, and we analyzed several outcomes. In the end of the selection process, we had 47 eligible articles. We had 23 articles that use more strict, more homogeneous histological classification according to Red Lines criteria. And because of this homogeneity, we ran the analysis both on this smaller group of articles and both on the whole pool as well. And I will note if there were any difference between the analysis. Here is the list of our outcomes, and these are the major morbidities of prematurity. One of our primary outcomes is mortality, and as you can see, we conducted a subgroup analysis as well using the mean gestational ages of the studies. We created one with higher, one with lower gestational ages using the 28 weeks as a cutoff. And according to the 16 studies, we found no significant difference between the two groups of neonates. However, we can see a slight tendency towards neonate with fetal inflammatory response. Early onset sepsis is a sepsis occurring within the first 72 hours of life, and analyzing early onset sepsis, we found non-significant elevation of the incidence of sepsis among neonates with fetal inflammatory response. We found similar distribution with a smaller tendency in case of late onset sepsis. Necrotizing enterocolitis is one of the most common gastrointestinal emergencies among preterm neonates, and here we found no difference between the exposure and the comparison group. Bronchopulmonary dysplasia is a respiratory morbidity of prematurity, and here, as you can see, according to this more than 20 article, we found no significant difference. Only a tendency towards neonate with fetal inflammatory response, but this is an analysis of the whole group of articles. In case of the selected group of articles, we found this elevation to be significant among neonates with lower gestational ages. We analyzed several neurological outcomes as well. In case of intraventricular hemorrhage, we found a significant elevation of intraventricular hemorrhage among neonates with fetal inflammatory response. However, this association was not demonstrated in case of the selected group of articles, neither in case of analyzing only severe intraventricular hemorrhage. We analyzed one maternal outcome, clinical chorioamnionitis. This is signs of chorioamnionitis prenatally, and we found it to be elevated threefold higher among infant mother diets with chorioamnionitis and fetal inflammatory response as well. All in all, the strength of our study that we only use studies with histologically confirmed chorioamnionitis, and as I mentioned, we have this selected group of articles, but just as important are limitations that in certain articles these outcomes are based on slightly different criteria, and these outcomes are multifactorial and highly influenced by different confounding factors such as gestational age or mortality, to which these data were not adjusted. In conclusion, we can say that despite of the theory that fetal inflammatory response is a progression of chorioamnionitis, after analyzing several outcomes, we found no difference or only a trend in vast majority of the cases. We found association in case of intraventricular hemorrhage and among extremely preterm infants in case of bronchopulmonary dysplasia. And our analysis shows that chorioamnionitis with fetal inflammatory response is clinically much more apparent than chorioamnionitis alone. In summary, our implication for practice is that histological examination of the umbilical cord within 24 hours should be incorporated in our everyday practice, and it can be part of the prognosis evaluation as well. And in case of clinical chorioamnionitis, a progressed intrauterine inflammation should be suspected. Our implications for research is that fetal inflammatory response can be part of the basic characteristics of the studies, and conducting these meta-analysis, we met the same problem like other meta-analysis in this topic, that both adjusted and unadjusted data has its drawbacks, and the closest we could get to control all the potential or most of the potential confounders would be a meta-analysis with a meta-analysis of individual patient data. And our other implication is that to identify the possible pathways of the progression of intrauterine inflammation and its role as an independent risk factor. Currently, we are polishing our manuscript, and we are planning to submit it to the American Journal of Obstetrics and Gynecology. Our second project is a protocol of a randomized control trial, the effect of additional pre-extubational loading dose of caffeine citrate. One of the most common indications for intubation or reintubation are frequent episodes of apneas. And since the CAP trial, which is caffeine for apnea premature trial, there is an evidence that caffeine administration reduces continued apnea and is associated with shortened duration of ventilation. Nowadays, clinicians prefer to use non-invasive ventilation initially to avoid mechanical ventilation because of its consequences, such as bronchopulmonary dysplasia or reduced lung function. And that's why our aim is to investigate the effect of a higher level of caffeine in a quite vulnerable period of the neonates, the peri-extubational period. Our population will contain preterm neonates born before the 32nd gestational week is completed and had been mechanically ventilated for at least 48 hours. It is planned to be a two-arm study with the intervention of 20 milligram per kilogram loading dose of caffeine citrate 1 hour before extubation. Our primary outcome is reintubation within the next 48 hours. Our implication is that caffeine can decrease extubation failure and mechanical ventilation day, and thus BPD, and this study can contribute to finding the optimal dosing regimes. Here are our eligibility criteria, both inclusion and exclusion criteria, and we conducted a sample size analysis as well, and we are planning to do an interim analysis. Beside our primary outcome, we have secondary outcomes as well, like frequency of apneas, heart rate, or gastric residuals. This month we applied for the ethical approval, and we are waiting for the results, and we are planning to start this trial in the beginning of October. Here is a quick overview of our planned two projects, and thank you for your attention. My quote is, "From a tiny spark may burst a mighty flame."
I mean, regarding your first topic, it's worthwhile to launch a national guideline.
Sorry?
Regarding your first topic, it's worthwhile to launch a national guideline. Hopefully.
Yes, I hope so.
I've got a question related to actually for both of your projects. You mentioned there's an outcome in the first project, the bronchopulmonary dysplasia. And how is it related actually for the fetal inflammatory reaction? Because I don't really understand the pathophysiology at the background. So could you tell me some, because I'm just a gastroenterologist, I don't understand what's going on here.
Actually, bronchopulmonary dysplasia is a multifactorial disease, as I mentioned, but definitely we can identify an inflammatory part of this disease. And it is shown that inflammation has a huge part in bronchopulmonary dysplasia, and also the different noxes from mechanical ventilation, such as volume trauma or barotrauma.
Did you analyze the placenta? So in the baby, the placenta was analyzed for the chorionitis, or a chorion biopsy was taken during pregnancy?
No, it was the specimens from the placenta. The whole placenta went to the pathology, and they...
Okay, in such a way is clear.
I would like to ask about your second project, the trial. So if you see that the additional caffeine is working, do you plan to maybe try a higher dose or some additional cycles, or do you think it might be useful in that case?
Thank you for your question. Our study will focus on extubation failure. So if we have a significant result that caffeine reduces extubation failure, we can only say that it reduces extubation failure. And yes, we can think of further studies with higher doses, but in those cases, when we use more than 20 milligram per kilogram every day, each day, as a maintenance dose, we would need to control the drug level like every day in the neonates, and that would be difficult.